Thank you very much for the introduction. I'm very honored to be here and speak about my dissertation topic. I'd like to speak about kidney function by creatinine and cystatin C, adverse cardiovascular outcomes in patients with atrial fibrillation. So there's an issue with the, yes. So imagine we have a patient with newly diagnosed atrial fibrillation and a reduced kidney function. What do we do? I think we all know this patient has a high risk of stroke, so we calculate the Schweigler score and probably give him oral anticoagulation. But even though the patient now is on oral anticoagulation, he has an increased risk for ischemic events and major bleeding, as well as an increased overall mortality. In this situation, an accurate estimation for the kidney function is key for a proper risk assessment. We normally do that in clinics by estimating the GFR based on creatinine. That's how we do it in clinics every day. But how could we improve our GFR estimation in clinics? Well, maybe that's the answer. Cystatin C is a protein produced in all nucleated cells all over your body. It is almost completely reabsorbed and catabolized in your kidneys. And it is independent from muscle mass, which is one of the major limitations of creatinine. It is also not affected by autoimmune or consuming disease, although this point is in a lot of discussion recently. Again, some trouble with, yes. To my study design, we have almost 4,000 patients from two big observational multicenter cohort studies, the SWISS-AF and the BETA-AF study. Here you see the map of Switzerland with all the centers. The main inclusion criteria was, of course, atrial fibrillation, an age over 65, and no acute illness for the past month. Then we collected blood samples at baseline and calculated the GFR. We did 3 different kinds of calculations, so there was one based on creatinine as the gold standard, one based on cystatin C, and a combined formula with both biomarkers together. Then we did multivariate Cox regression analysis and calculated the hazard ratio. Our primary outcome was major adverse cardiovascular outcomes, events, short MACE. This is a composite of stroke, systemic embolism, myocardial infarction, and cardiovascular death, so mainly ischemic events. And in addition, we did major bleeding as well. Aim of the study was to compare the association of the 3 different GFR models with MACE and major bleedings. Already coming to the results, here you see the baseline characteristics stratified by the combined GFR. You can see that from our 4,000 patients, 71 was the mean age and 28% were female. You see the Schweigler score, and you can nicely see that the lower the GFR, the more comorbidities the patients have. Here we see the type of atrial fibrillation, and here you see the higher the GFR, the more paroxysmal AF the patients have, and the later or the lower the GFR, the more permanent or persistent atrial fibrillation. Here you see that 84% are on oral anticoagulation and 48% on VKA. That's mainly because the baseline of the study was 8 to 10 years ago. Now it's a bit lower and a bit more NOAC. Here you see a forest plot of the hazard ratio of the multivariate Cox regression analysis. Here on the bottom, you see that it's adjusted for 11 different possible confounders, and the results are standardized. So all results are per 1 standard deviation to make them all comparable with each other. You can see that MACE is significantly associated with all 3 different GFR models, as well as cardiovascular death. But more interesting is that major bleeding is not associated with the GFR based on creatinine, but still is significantly associated with the GFR based on cystatin C and the combined one. Here you see two ROC curves for my two major endpoints and the three different GFR models and the area under the curve. I can tell you all GFR models differ from each other significantly. And as you can see in both graphs, cystatin C seems to perform the best. Already coming to the conclusion. So GFR based on cystatin C is associated with ischemic events, as well as major bleedings and cardiovascular death. So maybe it gives a more complete risk stratification in patients with atrial fibrillation and reduced kidney function. We also have some limitations. Due to the study design, no real causality can be inferred. And we have a quite small number in the lowest GFR group on the 30, but it's still over 200 patients. And as always, there's still further research needed in this field to really be sure about the data. And with that, I want to thank you for the opportunity to be here, and I'm really looking forward to present my data then in the EST in August. Thank you very much.
Yeah, thank you very much. Any questions from the floor? Meanwhile, I would like to ask you, I think the ROC curves were quite similar. They are numerically different, but the difference is very small. So do you think that this translates to some clinical benefit if you assess your patient with cystatin instead of the more cheap and more available creatinine method?
Yeah, I knew that point's coming with the cost. It is one of the major limitations, the cost of the cystatin C. I think even though the ROC curves are quite similar, it is significantly different. And I think that cystatin C is also associated with major bleedings. It gives a better or a more complete risk stratification. I think it could improve our stratification in this special setting I told you.
Any more questions? So what is your thought about other new renal markers like, let's say, NGAL or KIM1 or PENK?
Well, I cannot say a lot about other biomarkers because we really were limited because the study was not focused on nephrology. But I can say that I think with this data, maybe cystatin C would be interesting to have further research about.
However, the clinical use of cystatin is limited. I think in only one trial, the ROSE trial, was the end point. In all other trials, the GFR changes is the end point in clinical practice. That means that we need more data about that in clinical practice. Okay, thank you very much. And we will move to the next.